Welcome, everyone. I think in the interest of time, we'll probably just move right in. I think everyone knows the fabulous Dr. Gabe Wagner. We are all very lucky to get to work with him. It's funny when Gabe and I introduce ourselves together, we basically said what that person said because we do similar stuff, have similar interests in research, and Gabe is going to talk about closing gaps in HIV PrEP uptake today. And Gabe, I'll keep an eye on the chat.
Thank you. I have no disclosures. All right, good morning, everyone. So this is going to be the outline for today's talk. I'm actually going to be talking about some key, important, and interesting topics that I read about, borrowing heavily from this year's CROI and other recent presentations to discuss some of the key problems today when it comes to disparities in PrEP uptake. We're going to talk about social and structural determinants of health. Going to jump into some new ways of thinking about the problem that include novel frameworks, interventions, and deliveries for PrEP. And then at the end, gonna talk real quick about a new up-and-coming study that I'll be involved in that is a pharmacy PrEP implementation study. All right, and I'll start with this slide, which I was looking at the last time I did high rounds. I used this same slide, but it's still very relevant. This is data that the CDC presented at last year's CROI that shows the estimated lifetime risk of HIV diagnosis in the US among cisgender men. And here they used data from 2017, 2019 from the National HIV Surveillance System, mortality data, census data, to calculate the probability of diagnosis of HIV. And just by way of comparison, so the risk, you can see my cursor, right? The risk is here on the left, and the subgroups are here on the bottom. Just by way of comparison, people in the US run a 1 in 120 lifetime risk of HIV infection. And yet, when you break it down by race ethnicity, you can see that actually the subgroups have widely divergent risks of lifetime risk of HIV, with white Asian populations significantly lower than Black Hispanic populations down here in the bottom, with the Black group 1 in 127 risk of lifetime HIV. And this is to show that the HIV incidence is actually significantly improved, right? So I think many of us in the audience already know this. These are, again, data from the CDC showing the estimated HIV incidence, persons aged greater than 13 years from 2010 to 2019. And the little asterisk over here on the right shows that there has been a statistically significant decrease by 12% in the HIV incidence overall from 2010 to 2019. And this is great. This is due to evidence-based interventions and things such as PrEP for HIV prevention. But when you break it down by race, ethnicity, and the bulk of the HIV incidence in the US is among men, and especially MSM, then you see the disparity. So this is, again, looking at 2010 to 2019. And what you can see is that that significant decrease, the orange line, is actually driven by the white subgroup. The Black, African American, and Hispanic Latino lines are actually been pretty stable, which is not good. And the Black African American line, as you can see, is much higher than the white subgroup line. And this, the fact that we can see this more clearly now, or in 2019, really does suggest that there is a problem when it comes to the widening disparity of HIV incidence and of HIV prevention services that really does need new dramatic ways of tackling. And this is to show the actual PrEP coverage. So this is estimated PrEP coverage. This graph, I think, has been shown many times. This is now updated with CDC data from 2021. And it is better. So this is the estimated PrEP coverage on the left. And you can see here, so 50%, this is the target goal for the ending the HIV epidemic, to get 50% of eligible people on PrEP by 2025. And you can see that things overall are encouraging. This number, so it's right now a little bit less than 1/3. This number has increased dramatically. Like in the last several years, it used to be like less than 20, not even a couple of years ago. But again, you can see that the bulk of that is being driven by the white subgroup, and the subgroups that actually need it the most have the least amount of uptake. And this is important because the ending the HIV epidemic goals and priorities will not happen without addressing disparities to HIV prevention access. So this is a study, this is a modeling study that was done across 6 cities, looking at the HIV incidence and HIV incidence rate ratios across these 6 cities. If you were to take HIV prevention testing treatment services at the status quo in 10 years, and if you were to do an ideal implementation where you're essentially targeting more than 90% of the target population with these interventions. And so, and here on the left is a comparison of the incidence rate ratios, Black versus white, and on the right, the incidence rate ratios of Hispanic versus white. And so, for example, if you look at the top, this is the city of Atlanta, 2020 estimates. If you were to stay status quo, it would be about the same. Not much change in the incidence rate ratio. And yet, if you utilized ideal implementation, then you would have a significant improvement. The green bar here, and this is Hispanic versus white. I mean, it's not great, you know, so this would be 1, right? This would be like complete equity. None, in very few, it doesn't reach that in many cities. But nevertheless, if things remain status quo, the access disparities will remain. Okay, so let's talk a little bit about social and structural determinants of health, because what is driving these disparities? The disparities, and I borrowed heavily from Dr. Lauren Nelson's talk at CROI, which was fantastic, and I do recommend that folks listen to it online if they get the chance. You know, what he mentioned was that, you know, obviously the metabolism and processing of biomedical PrEP interventions is not different depending on white or brown or Black skin. What does make a difference is that there are these social and structural determinants of health that we have known for some time are playing a big role. So this is, on the right, is an illustration of a report from the CDC. This is back from 2008 that looked at addressing social determinants of health. So this is all the way from 2008. So for a long time now, we've known that without addressing these social and structural determinants of health, these disparities will remain, and because these have a very real impact on the acquisition of HIV and other STIs. And we're talking about things such as unstable housing. Obviously, if not having a house might make it complicated to take a daily PrEP medication. Unemployment, incarceration history. So if you are incarcerated and then come home, you have limited opportunities for employment, which is necessary for generating income and having employer-based insurance which significantly impact your ability to access prevention, HIV prevention, and other STI services. And these social and structural determinants then translate to barriers to access, and these have been well described. There are multi-level. This is a great paper by Dr. Bonacci, and in it, so they lay out a couple of different level barriers. These are, when we talk about individual and network level barriers, we think about things such as the lack of awareness about HIV and PrEP, that there is a discordance between the actual risk that someone is at for HIV and the perceived risk. Concerns about side effects, which could have significant impact on HIV PrEP interest and uptake. Competing priorities, so housing, you're worried about food, shelter, childcare. PrEP may be lower on the list. Stigma, which is very important and highly complex. There can be stigma related to HIV, related to PrEP, heterosexism, medical mistrust, racism, and how these different components can intersect, intersectional stigma, and how much that is compounded to not be able to access PrEP. And social and sexual networks may impact awareness of PrEP and enforce norms and expectations regarding PrEP use or non-use. There are also healthcare system level barriers. So there are clinician-related factors, bias, racism, sexism, homophobia, transphobia, the stigmatization of people with substance use disorders, lack of PrEP knowledge, concern about risk compensation, which we now know is not an issue, but there may still be providers out there that do believe that it is. There are also factors that impact prevention and care deliveries, care service delivery, and these include things such as misscreening for HIV PrEP, indications for HIV PrEP. In the 2021 updated guidelines, this really should no longer be an issue. Everyone who asks for PrEP should be prescribed it, but some providers may not be aware. There's also the purview paradox, which has improved. This is the issue of what is the appropriate clinic for the appropriate setting for PrEP delivery. Primary care clinics may be unfamiliar with antiretrovirals, and HIV specialty clinics may not provide PrEP services. And mistrust of clinicians and health institutions, which also functions at this level. And then there are also structural level barriers, and these include financial barriers, real and perceived. They include distance to PrEP providers and lack of transportation. So data from the Emory group nicely laid out in a year or two ago, using census data, how there's these PrEP deserts, which oftentimes can be concentrated in counties in the US that are heavily Black and Latino. And policy decisions, so Medicaid expansion and jurisdictional PrEP assistance. So here in California, we are fortunate to benefit from Medicaid expansion and from jurisdictional PrEP assistance, but not all settings might. There is immigration status and limited English proficiency, which can also play a barrier, and medical and government distrust. All right, so knowing that these social and structural determinants of health are present, what are some of the ways that we can frame interventions to address them? And again, I borrow from Dr. Nelson's talk at CROI. He did a wonderful job of showing how to reframe these ideas and how to reframe the equitable implementation of PrEP. Because social and structural determinants of health are not static, right? I think they must be actively counteracted. So if drivers are not counteracted, the introduction of new innovations in PrEP will produce inequities because the benefits are differentially funneled to groups assigned privileged status, such as those with insurance or those who own a car. And this is important to understand for folks because social and structural drivers can be targeted. I think, and he talked about this, how we in the research world tend to think that these determinants are non-modifiable, when in reality they can be. And these include targeting organizational practices and policies that contribute to inequities, targeting norms across institutions that reinforce inequities, and targeting political and economic incentives that reinforce the inequities. You know, as was said, if it wasn't benefiting somebody or some people, it wouldn't be happening. It is reinforced because it does produce the benefit for some. And he showed this. This is a trademark concept that was advanced by Grand Challenges Canada for their global health priorities. But this is it's a nice way of thinking about this integrated innovation, where scientific technological innovation at the top of this figure is combined and synergistic with social innovation and business innovation, and together they address the problem. And this can be utilized in the space of HIV prevention. So scientific innovation, we already know that we have long-acting injectable antiretrovirals for PrEP. We already know that they're highly efficacious. We already know that there's current products and future products coming down the pipeline. But the point is that at the same time as a research trial is conducted, we should be thinking about social innovation, not post-trial, but actually as the trial is being considered. And social innovation should address one or more of the social and structural drivers of inequities. It should it can incorporate the political ecological lens that takes into account how the place, the setting, the geographical setting will influence implementation and scale, right? Upscaling of long-acting cabotegravir in San Diego may look different than in Lima, Peru. And develop and deploy tools that will minimize barriers to access. So this includes financial barriers, and it includes barriers that activate against the intersectional identities of gender, race, sexuality, health status, and this includes people with substance use disorders, religion. All of these things need to be taken into account at the same time as we are considering efficacy of interventions. And then there's the business innovation side of it. So in this example, it would optimize the value of long-acting injectable PrEP to create demand, address affordability and accessibility of long-acting injectable PrEP, and develop affordable business models that align with national, state, and local policy priorities. So for example, in the US, to align with the EHE ending the HIV epidemic priorities or other targets. And create incentives for those whom PrEP will impact. And this includes not just patients, but health business operators, because without the bottom line, the whole system would not function. So in the talk, they laid out this new science of impact, which is a very engaging and compelling way of thinking about the problem. that, so as you can see here on the right, the biomedical interventions, such as PrEP, long-acting PrEP, all forms of HIV prevention and future products are thought about, but not the efficacy. We cannot only design with efficacy in mind, we must also at the same time consider the structural and socio-behavioral interventions. And in this particular talk, they talk about this study that is up and coming, HPTN 096, Building Equity Through Advocacy. It's a study that uses a combination of interventions to address structural, social, and behavioral challenges. And interventions are tested together as a package and are intended to be synergistic. And this is important, again, because it's so in this the subgroup analysis for Black MSM and transgender women was presented as part of the HPTN 083. Hyman Scott presented for the HPTN 083 study team. And I just decided to summarize basically the findings. I didn't lay out the nitty-gritty data here. But what they found was that HIV incidence was higher among Black MSM and transgender women than non-Black MSM and transgender women. They found that protective efficacy of long-acting cabotegravir versus Truvada, TDF-FTC, remained high among Black MSM and transgender women. And they found that TDF-FTC adherence was lower among Black MSM and transgender women than non-Black MSM and transgender women. And they found that long-acting cabotegravir adherence was high among both groups. So just to remember this, the HPTN 083 is the study that brought us cabotegravir a couple of years ago. And I'm glad that this subgroup analysis was conducted because it very much only emphasizes the points of the talk. Number one, HIV incidence was higher among Black MSM and transgender women. And number two, TDF-FTC adherence was lower among them. And yet CAB-LA adherence was high among both groups. So really, it is now we have hard evidence that this group might benefit well from this type of HIV prevention. So this could be a powerful HIV prevention tool to increase access to PrEP and address racial disparities if the proper implementation considerations are taken. So going to talk a little bit about some very interesting things that were talked about were some of the priorities and efforts that are going on in sub-Saharan Africa. So these are efforts to accelerate the equitable delivery of cabotegravir. So it really, from their perspective, and with the experience of oral PrEP and the failures, understanding that it requires a multidisciplinary implementing partnerships and collaborations. And the two that they mentioned that I'll mention briefly here, one of them is called the Biomedical Prevention Implementation Collaborative, and the other one is the Mosaic Project and its study, which is called Catalyst. And so this biopic was established to address gaps in advanced coordinated planning for product introduction in the rapidly evolving HIV prevention space. And this collaborative is all sorts of different stakeholders, and it builds on previous product introduction experience with oral PrEP. So as we can see here on the left is some of the lessons learned where key components of the product were not well timed, and due to a complex fragmented stakeholder landscape, post-approval studies were not designed to answer critical questions. And over here they lay out the ideal product introduction experience, where you plan in parallel to clinical trials these to shorten the time between regulatory approval and large-scale phased implementation projects in low and middle-income countries, so that the factors that go into the consideration of implementation are done in parallel to the efficacy trials, and coordinate stakeholders in advance. And the other collaborative initiative that I wanted to mention is this very interesting maximizing options to advance informed choice for HIV prevention called Mosaic. This is a 5-year global project funded by PEPFAR, and it focuses on biomedical HIV prevention products for women in sub-Saharan Africa. This is a close collaboration with ministries of health, missions, implementing partners, civil society, end users, providers, and other stakeholders and product developers. And its study, which is called Catalyst, Catalyzing Access to New Prevention Products to Stop HIV, will utilize mixed methods to characterize and assess implementation of an enhanced service delivery package, providing choice of PrEP products among women at PEPFAR delivery sites. And so the study design, you can see here, implementation of enhanced delivery package includes components at the individual, provider, facility, and community levels, and uses quality improvement methods to refine components. So this brings me to a point about novel models of care that we now have to support PrEP uptake and PrEP persistence. And the field has moved significantly, and it's very exciting. We have things such as mobile clinics that can meet clients where they are. They're key population friendly, community engaged, and they can provide comprehensive sexual and reproductive health services. We have peer-supported PrEP delivery. So this includes peer navigators, peer PrEP clubs. These types of environments can reduce stigma and prioritize social motivations. So the demedicalization of PrEP has been found to be quite impactful for some groups, especially young people. We have pharmacy-led PrEP, and I'll talk more about this in the last portion of my talk, but basically, pharmacies can have extended hours, lower barrier access, and they can be neutral environments. And we have mHealth and telemedicine, video evals, home testing, mobile phone apps that can help with privacy and personalized care. This has been significantly upscaled as a result of the COVID pandemic, and hopefully that momentum can be leveraged. Oh, a quick word about this very interesting pilot randomized controlled trial in South Africa, just to think about some of the ways that delivery services can be leveraged. So this is they assessed uptake of PrEP and contraception in hair salons in South Africa. So the stylist in the study would introduce the study and then refer them. There would be like a research coordinator or a nurse there that would be able to facilitate questionnaires, testing, and offer PrEP and contraception. And I didn't lay out the actual data here in the conclusions. This is just to let you think about some of the more provocative ways that where delivery environments can occur. But I can tell you that in their study, it was highly acceptable, highly feasible. The uptake of contraception was significantly higher than the uptake of PrEP. And this is another project to consider HIV and STI prevention choices among men who have sex with men. This is the Peach project, Project Peach, out of Emory. This is Dr. Kelly's talk at Croy, and this is an ongoing observational cohort of young MSM in Atlanta. And here they are given options, right? Choice is very important. So daily PrEP, oral PrEP, 211, oral PrEP, and doxy-PEP. Participants can start, they can stop, they can change prevention choice at any time. And this is supported with navigation, mHealth study app, and peer counselor motivational interviewing support. And this is just to show that their study is ongoing, but already you can see that there's a smattering of different interests and preferences that individuals can have for the utilization of HIV and STI prevention services. And just a quick plug for our own local-led PrEP studies, the Nexus study, Open study, and I think the ESTEP study will be coming soon. Okay, so wanted to conclude this part of the talk. So disparities in PrEP uptake are driven by structural and social determinants of health. To reach the goals of HIV eradication, ending the HIV epidemic, it is necessary for governments, ministries of health, health departments, end users, researchers, community partners, and other stakeholders to really collaborate and implement innovative programs and policies, and broader structural reforms that address underlying social, economic, and political determinants of health will be key. So before I move on to the pharmacy PrEP implementation study, any questions so far, Jill?
There were no questions. I just had a quick comment. The randomized control trial in Africa with the hair salons. I think it's a fabulous idea. I remember when we were trying to enroll cisgender women for a PrEP study, like in 2014, 2015, we were struggling, and I spoke with a lot of people who were involved in a lot of the cisgender women studies in Africa, and that was their suggestion: go to hair salons. That's where it's at. We tried it; it didn't really pan out the same way here, but it's interesting that this clearly is a model for them that works, and it's sort of just informs the idea, like figure out what your local, what's needed locally and try to use that as much as possible. But just a very cool idea. That's it. Sorry, go ahead, Gabe.
Thank you. Okay, so as many of us here may know, California passed the Senate bill that authorized the pharmacists to furnish PrEP without a physician prescription up to 60 days. That was actually went into effect in 2020, but it hasn't really picked up very much. And so this is a study that came out earlier this year, Berkeley Public Health. And in it, they found that 11% of California pharmacists surveyed had prescribed the medications, and only 72% had heard of Senate Bill 159, and less than half of respondents felt confident in their ability to prescribe PrEP. So this is part of the problem that they found, is that most pharmacists value their role in providing essential sexual and reproductive health services, but many face policy and organizational barriers to implementing them in practice. So this is a study that is being led by an implementation researcher at Johns Hopkins University, Christopher Kemp. The title is Identifying Capacity and Strategies for Community Pharmacy PrEP Implementation to End the HIV Epidemic in the US. And they originally tapped Jill, who then passed the baton on to me. And this is going to be looking at two jurisdictions, San Diego and Baltimore, where Hopkins is located. But by way of background, as we talked about before, so many high-risk individuals don't have access to, do not access HIV specialty clinics. They do not access public sexual health clinics and other traditional primary care settings for all the reasons that I mentioned previously. And so pharmacies can be well positioned for accessible PrEP services, They are ubiquitous in neighborhoods and in communities. They can have expanded hours and walk-in capabilities. So, and importantly, they have the potential to reach populations that are not currently engaged in HIV prevention. You know, I often talk about our PrEP clinic at the Owen Clinic, which is fantastic. We have this incredible and robust program, but it means that people have to have the right insurance. They have to be able to come to us. And so, as we talked about previously, and even with the example of hair salons, trying to reach populations that are not currently engaged is going to be key. And so the characterization of the current landscape and the delineation of key elements for implementation of pharmacy-based PrEP is really needed to promote uptake and to mitigate current disparities in PrEP utilization. Okay, so these are the project goals and objectives. So this is going to be a multi-site collaborative study response to EHE topic area, strategic alliances across jurisdictions to reach EHE goals through implementation research. As I mentioned, this is going to be across 2 EHE jurisdictions, Baltimore, Maryland, and here in San Diego. So it's going to be an inter-CFAR and inter-implementation science technical hub initiative. And the overall objective is to build strategic alliance across 2 HE jurisdictions and to develop implementation strategies to support pharmacy-based PrEP implementation at scale. Okay, so these are going to be the key research questions. Question number 1, what is the extent of, capacity for, barriers to, and facilitators of equitable implementation of each component of PrEP service delivery across community pharmacies? So this is really landscape assessment of kind of where we're at, where are we at, what are pharmacies doing, and what is needed. So this is using brief quantitative surveys and in-depth key informant interviews to conduct a landscape assessment. Question number 2 is, what are the preferences of individuals at higher risk of HIV infection for pharmacy-based PrEP across each partner EH jurisdiction? And here, the method will be to deploy a discrete choice experiment and invite individuals at risk for HIV to participate, basically to choose different components and which components of pharmacy-based PrEP delivery they would choose, which components they would prefer. And finally, question number 3, what implementation strategies are suitable to support pharmacy-based PrEP within each partner EHE jurisdiction? And for this, the intent is to use focus groups and implementation mapping methods to develop a menu of implementation strategies that are mapped to the needs and capacity of each content. And with this information, then move forward with a fuller implementation clinical trial. Okay, okay, so these are the methods, and I kind of already spoke about the barriers. So the different aims. So you know, in the first aim, we're going to be looking at barriers and facilitators, and this will include brief surveys of pharmacy technicians, about 200 per city. And the key question is going to be, what are pharmacies doing now? And then we will also be using key informant interviews, pharmacists, pharmacy technicians, and other PrEP providers and state-level policymakers, about 12 per city, to ask what are key barriers to pharmacy PrEP. And then in the second aim, when we look at preferences, we'll use discrete choice experiment for folks for whom PrEP is indicated, about 100 per city, and ask, what do potential clients want pharmacy PrEP to look like? And they will be presented a choice menus that they can select out of what they would like, what specific component they would like out of pharmacy-based PrEP. And then finally, implementation mapping in 3 focus groups of pharmacists, pharmacy technicians, other PrEP providers, and state-level policymakers, 2 per city, and 4 to 6 providers per group. And the question here will be, what are the best strategies to support pharmacy prep? And with all of this information, then move forward with an actual package of pharmacy prep implementation. So any questions around that? Because I think this may be the end. A little short.
No, perfect. This is the amount it should be. So then there's time for dialogue and people can take the time they need to move on to their next thing. Nettie, do you want to? So first of all, thanks, Gabe. And I do think that the pharmacies are an untapped resource. It also probably depends on the pharmacy, and I'm putting in quotes, its priorities. Nettie, do you want to say? Do you want to unmute
Sure, yeah.
yourself?
No,
Sure.
I was just thinking about, like, the idea is really trying to get sort of outside of traditional spaces, right? But then into spaces where people feel comfortable. And so the pharmacy, it's outside of traditional spaces because it's out in the community and there's many of them, et cetera. But I don't necessarily think of all of them as being spaces where our patients who don't generally access care feel safe or comfortable or feel like it's where they hang out, or you know what I mean? So it's one of those tricky things where the resource is there, but it may or may not be matched to the gap, the care gap. And so how to bridge those two. And of course, that's probably one of the things you're going to be thinking about, but I just wanted to kind of explore that notion, right? Is you have this big resource, but it may or may not be sort of trained up to be welcoming or open or access our patients who aren't accessing care elsewhere. I'm not sure that they would necessarily just find the corner CVS necessarily to be someplace where they feel comfortable. We're not talking about over the counter, so they have to speak to someone. So that person has to, know how to engage them and whatnot. So then I was thinking, the specialty clinics probably know how to do it, but that's still kind of a very limited population. So I was just curious what you thought about that, Gabe. And thanks for the talk.
Yeah, thanks, Nettie. Yeah, you're absolutely right. So these, of course, would be just some efforts because the overall problem is actually quite large. So these efforts at pharmacy prep is just one component of it. Other trials should definitely look at, well, there was the example of hair salons, but other trials maybe you can look at rec centers or other environments. And within the pharmacy space, the truth is we do not know. Perhaps there are some pharmacy spaces that are more welcoming than others across jurisdictions throughout the U.S. But yes, that is just one.
And interestingly, the resource is the pharmacist, not necessarily just the pharmacy. So, mobilizing that workforce, even if it's not just in the corner CVS, but just mobilizing that workforce and seeing how you could pair that workforce with environments where people might be more interested in accessing care, might be a novel way to combine the resource with the community needs.
Exactly, because I think we think we know that they are well equipped to handle this, but in reality, this is why it would be important to do such a study to really understand from the pharmacy technician perspective what exactly is needed. What are the barriers? What are the infrastructure problems that really need to be addressed to really scale this up?
Hey, Gabe, thanks for the talk. If I could just add a comment about, well, I'm going to be very interested to see what the results of this study are from these surveys, and just from a kind of observation about SB 159 and kind of the lack of uptake about the implementation of this in pharmacies. I think a lot of it is just it's systems barriers from the health insurance perspective, right? Because our health insurance system isn't built to reimburse for clinical services in pharmacies very well. And so I think one of the biggest things is like how to if this gets scaled up in pharmacies, how is that, how are those services reimbursed? Because there's even very poor mechanisms just to get reimbursement for doing an HIV test in a pharmacy. And a lot of places are not built out to do that. And it's not that it can't be figured out, because it probably can, but I think that's one of the problems with SB 159 is it's idealistic to say that these services can be offered in pharmacies, but how do pharmacists get paid for those clinical services? Like, for example, we have trouble billing for clinical services that the pharmacist provide at Owen Clinic, and that's in a clinic space, right? And that's not even in an outpatient, retail pharmacy. So I think that's been one of the challenges. And then the other is just a lack of ability to do these simple laboratory monitoring tests in outpatient pharmacies. Getting a creatinine is not as easy as it sounds if you're not linked to a clinic or a lab and things like that. So anyways, very curious to see what the results are, but I know that especially in San Diego, many pharmacies are aware of SB 159, but just haven't really figured out how to work through the system to implement it.
Yeah, thank you so much, Lucas. I may have found at least one key informant. No, I'm joking. We can discuss offline. Of course, it'd be really nice to talk to you.
For sure.
Yeah, Lucas, I mean, with all of this stuff that you just said, I think the thought with the reimbursements is that, well-funded pharmacies or well-resourced pharmacies, it wouldn't be a big issue. They could probably eat the costs for doing some of the things that you bring up. But obviously not for smaller, specialty care pharmacies. So it's a really good point. I know we could argue about creatinine more. I feel like it's going further and further by the wayside, whether we actually need it for PrEP, how infrequently it becomes an issue, but that's what the recommendation is right now, obviously. And I don't think places that don't do it regularly will, feel comfortable not having it. And that is a big issue if you can't do that. And then also STI testing, right, as sort of part and parcel to this. So
hepatitis testing, all of that stuff. Yep.
Yeah. Again, probably not a huge deal, but we do see it. We do get those surface antigens that are positive occasionally. So I think Kathy is a great question. And Gabe, I don't know if you can see it. I can read it. Is Amazon thinking about doing PrEP? I thought they were trying to tap into healthcare. And I'm assuming you mean like the whole kit and caboodle, Kathy, like you sign up, you get your testing delivered to you. Or maybe not, but I know I have patients who get their PrEP via Amazon Pharmacy, but I'm assuming we're talking about more of the care.
Yeah, I'm not. I don't know. I don't know about that. I don't know the details of it, but M Health for PrEP, and already there have been several players on the market for several years. It doesn't surprise me that Amazon would move into this space also, like commercial e-health apps.
I just did a quick Google search, and there's nothing specific other than that, they have it in their pharmacies, and then also a lot of books about PrEP.
That might be a big one. Their reach is big.
No, it's actually a really interesting concept. But of course there are other health apps. There's Folks, there's Plush Care, there's Nurix. I don't know if Nettie's been.
Yeah, I was just going to comment. I mean, yeah. We always talk about worries about making sure people get STI tested. Just sort of a general compartmentalization of healthcare, like get this and this over here and this over here. And I always really advocate more for a partnership approach so that you can seamlessly be at your pharmacy, but they can direct you over to your STI testing, so that it's not always on the patient to go from here to here to here. And it's a soapbox of mine about healthcare in general, the sort of everything is getting sort of separated out. But for PrEP, we want it to be out there and available and, at the pharmacy and wherever the patient is. But I do think that programs should be building themselves with a collaboration so that you can be seamlessly helping the patient connect with what they need, so that we're not saying like, you just go get your PrEP at the pharmacy, but we can't do STI testing there. And we haven't really thought about how to make sure that you know how to do that easily, and that it's not some silo over there. You have to figure out how to hop over into a different silo. So that's I think something we need to think about when building these programs, or trying to say that we're going to be able to meet the patient's needs. Is a lot of the time we're providing one service, and then they have to figure out how to get the other thing that they need that's connected to that service. And HIV prevention, as we all know, is more of a comprehensive, holistic healthcare experience. That's not just the PrEP prescription, you know.
Yeah, no, and these multi-steps are definitely barriers.
And just to add to Gabe, one more thing about SB 159 is, you know, it really was designed to for maybe getting people on PrEP, but you know, the legislation's written to limit only 2 dispenses in a calendar year by pharmacists for PrEP. So it isn't meant for ongoing PrEP management in pharmacies, right? And I think if you're going to expand to these other locations, it requires collaborative practice agreements with clinicians and clinics for pharmacies to really do like PrEP management long term for patients. And so so I think it's a whole nother shift kind of in how the pharmacies partner with clinics to be able to provide the services.
Yes, it very much is. Yes, SB 159 is only for PrEP starter packs. It really does mean like a, you know, like implementation on multiple levels, for sure.
Not just starter, right? 30 days times 2 in the course of a year.
60 pills in 1 year.
Mm-hmm,
Yeah.
mm-hmm.
Yeah. Katie had another comment. Isn't there a major pharmacist workforce shortage, especially at large commercial pharmacies?
I do not know.
Lucas?
Yeah, they're
Yes.
walking out. They're walking out of CVS
Yep.
and Walgreens because they're overworked and not resourced enough.
Yeah.
Maybe they can come work in HIV, where we could create we could funnel some of those folks into the HIV workforce, where we also.
I was going to say where we have so many resources.
No, but we have need, and so you know, it's an idea.
I mean, I know we've gotten a couple of pharmacists that have come our way, which has been nice. But yeah, it's okay. And Kathy says they wouldn't be willing to eat their costs. Perhaps that was in my the idealistic brain of mine. But I do think the point is the bill that was created and the ability to just use pharmacists, even if it is for 30-day dispenses times 2, that's being very underutilized. And so I think, Gabe, the study that you're going to be doing is really going to be interesting to understand more about, why that is. And it sounds like, yeah, you found a key informant today. So anyway, and Dave has a question. How will the pharmacies address disparities? Yeah.
So, well, I mean, right. This would be in the discrete choice experiments. There may be components of where potential PrEP users may desire one approach versus another, taking into consideration privacy or other things. But really, the issue of addressing that is just the environment itself. The quote unquote demedicalization of folks just not having to go into an quote unquote HIV clinic, stigma and other things. But yeah.
Maybe you can have the final word after Nettie's sort of more sobering comment. We have an HIV workforce crisis.
I don't know. I mean, I'm just literally, honestly, people in this meeting speak to funders, speak to government entities, and we're all engaged in advocacy for what is needed in HIV for the future. And workforce is the buzzword. And so thinking about other parts of the workforce, including the pharmacy part of the workforce, is something that might, be a relevant conversation.
Thanks. Gabe, any last words from you before we close?
So I guess I would just say that yes, that was a sobering thought, but at the same time, hearing about these initiatives, these implementation collaboratives, and how people really are thinking about how to reframe the approach to service delivery really, I think is going to, it seems like it's already starting to take, at least in a few minds. And hopefully moving forward, we can really start to think outside the box so that we can best reach the folks that would need it most. Thanks.
Thanks, Gabe. Yeah, this was great. A really good, I always love a good prep talk, and this fits in really well. So thank you. And thanks everyone. We're off next week. Have a very happy holiday if you celebrate. Hope people get some rest and a little revitalization, and we'll see you on December 1st, which is World AIDS Day. So we'll see you at that time. Bye.